Hands on. And spread out. It's a very intimidating room for a Saturday morning at the end of the session. I'm Melissa Pally, and I'm here to present on behalf of her wife, and she was unable to attend today, so I'm speaking on her behalf. So just a few disclosures. Christine is a physical therapist. She works for Cravat, and I'm a physical therapist and also president. Oh, it just went away. Okay. Well, and we are the U.S. distributor for the Cravat equipment. And there's no financial disclosures for this presentation. So today we are going to get to know, looking at my papers just a little bit, because again, it's Christine's presentation. I am very familiar, but I want to make sure that I get their points across appropriately, and some of the different issues today. So let's talk about Marcus. Let's meet Marcus. Marcus is a 6-year-old. His favorite color is the entire rainbow. Let's see. So he does not sit much in a chair at school. He's either lying under the desk or running around in circles. At home, he sits at the dining room table, but his father has to backwards and forwards and will often tip over. His schoolwork is very challenging, and he's quickly loses focus and will often run off. He was fitted with a jockey size 2, takes out a book and looks at it with him while the mother asks many questions about autism and sensory processing. Autism is still very new to this family in this situation here, and why he constantly leans over the table and why he's so sensitive to certain stimuli. So as they sit there and they talk for about 25 minutes, he plays, the boy reads the book. Eventually they notice that he's becoming a little bit restless, so they ask if he's all done, and immediately he unclips the belt and dashes off. The OT shows the mom the clock, pointing out how long he actually managed to stay. She then says, "How do I get one of these for my son?" Thea, beautiful, bright blue eyes here, is 9 years old. Her favorite color is blue, and she loves gymnastics with an exclamation point. Complete homework at home. While the OT and the mother talk, she's constantly moving around the living room. She's full of energy. She's rolling off the sofa. She's talking nonstop, and she's explaining, look now, before cartwheeling across the floor. While she and her mother discuss challenges related to her restlessness and concentration. Her mother is also in the process of being diagnosed with ADHD. She still fidgets with her hands and her feet. So they discuss using fidget tools for her hands and placing an elastic band between the table legs so she can bounce her feet on. Extra support for her, but she worries that it may be wasted if her daughter cannot stay in one place long enough to engage in the learning activities, the use of the saddle seat that day. Keeps going in and out, sorry. So the neurological developmental disorders, let's talk about that, right? So these disorders are conditions where neurological and psychological development is delayed in childhood. They're two of the most common neurodevelopmental disorders, ADHD and autism, with a prevalence of about 5% of children and adolescents for autism. So, we all know the examples of engaged within autism spectrum disorders, Tourette's. Some other significant trauma can also cause some neurodevelopmental types of behaviors about. But our competence and our focus on this patient population is not really strong. There has been some increased focus in the media. Society really is not well adapted to supporting individuals in these learning environments and in our communities. We have seen a prevalence, an increase in autism. So the proportion of children and adolescents years between 2010 and 2022, you can see on the map here. Something very specific happened in in 2020, right? Girls in older age groups, especially those 16 to 19-year-olds on the graph. While for boys, the highest growth has been with 0 to 11-year-old group, 0.1%. In 2022, while for girls, it ranged from 0.2 to 0.8. So the number of teenagers diagnosed with autism and specialized healthcare services is rising. And before, we've got our levels of autism 1, 2, and 3, and there is some very specific characteristics for girls that are very different than those of the boys. So the overall contribution of us kind of autism in general, we're getting improved knowledge of professionals. And it's not just the clinicians and the physicians. It's healthcare clinics, adolescent psychiatric services, a little bit more aware because we're a little bit more understanding of some of these behaviors and movements. And there are more individuals with milder symptoms and typical intellectual abilities that are now receiving these diagnoses for every one girl. And some of these possible explanations based on some of the evidence they were looking at is girls have less pronounced symptoms. I have 3 boys. They are very rambunctious. Mind of play in our home environment, just by the nature of the development, typical development of a boy and girl. So there's stronger compensatory strategies in girls that might match genetic differences. And the diagnostic tools that we were using were actually more geared to see autism in the boys and not really pick up those characteristics in girls. So the prevalence and increase in ADHD, you can also see too. So HDA diagnoses in specialist healthcare centers for children and adolescents increased in both genders. This contrasts with, according to new data from the Public Health Report, which analyzes data from the Norwegian Patient Registry, the most significant increase was seen among girls 16 to 19, is that with ADD, symptoms became more visible to families as children spent more time at home during these periods of time. Additionally, homeschooling in front of a screen became, and those who had managed well in the routines and support provided for school may have struggled with the sustained attention when that structure disappeared. A lot of our children, going from a school program and having those activities all day and then going to the online learning was complicated for a lot of children, but just imagine the increased complication for those with ADHD. There's difficulty with the verbal and nonverbal communication. They don't always know how to express themselves, and there's difficulties with the social. So the limited areas of interest, there's particularly like Fortnite, right? So there's an area of interest that's very multiple areas of interest that a lot of children of more typical development may have. And there's often challenges related to the sensory experiences. And really, their fight and flight registry is not like ours. So it takes more or it takes less to make them really struggle. ADHD, again, attention deficit activity, impulsivity, often challenges related to executive function. They have a really hard time completing those tasks. So again, so on the graph, the bottom, the first column is no problems at all. The second problem is insignificant problems, moderate problems, significant problems, and serious problems. So 1 and Autism 2 study that they did. The green and blue are ADHD, 2 groups of ADHD kids that were looked, or people that were looked at for this. To mention, many children with autism also experience a lot of motor and muscular difficulties. So 80% of children and adults with ADHD, difficulties in regulating and adjusting force and flow movements was significant. And the regulation difficulties related in pain and muscle tension. So there are these are the movement assessment battery for children, then NUBU, NUBU 4 to 16, which I'm reading off here because I'm unfamiliar with this test, but this would have been Christine's partnership between motor competence and the neurobiological basis of children's and adolescents' functional motor skills by combining the test of soft neurological signs with motor competence for function examination. This was developed based on the observation by psychomotor physiotherapist Liv Larson-Stray, who did the study, and she noted they significantly struggled with everyday activities. So prolonged activities, they could complete the task the one time correctly, but they could not sustain the activity for long term. Role in the notice of impairment and balance, muscle tone, and the coordination. They were often delayed in their motor development, but certain motor skills were more met those milestones, but they were not as controlled as maybe someone who did not have ADD or ADHD. Now, when they were looking at the adults within the study, more widespread body pain compared to adults in those control groups, which then led to that 80% of children with experiencing motor difficulties of movements, which results in a lot of prolonged tension. So when we look at the motor and muscular impairments that we're looking at, there is a weak core. The stabilization musculature is just not there for mobility. They have a range, the range of motion in their trunk is more restricted. So the breathing patterns, they don't get as much oxygen through their body. And they're also that increases fatigue and a lot of other issues. They're primarily relying more on their the large muscle groups, which is also more fatiguing. So when we look at this, when we have postures like that for prolonged periods of time, we have a lot of tension. And a lot of that, it can be seen up in our shoulders and our neck, because if you have more of the collapsed posture, your shoulders are rounded in, your head is more forward, your pelvis is more rounded, and leading to chronic pain. So this is a lot of information, right? But I think this is a really important slide. Christine would have talked through this a little bit, but there's a new employee with Krabbit, and as she began working more with the company and listening. So I have to read it off the screen because that's too small. But she grew up without knowing she had ADD. For her life was just a series of challenges. She couldn't quite understand it. She played handball, and she just got really tired quickly, wasn't always as efficient as her peers, and she would get a lot of pain and cramps. Her parents insisted it because and so it was looked to think that she was being lazy, or she needed to focus more and pay more attention. The same applied to her schoolwork. She could sit for hours on a subject matter, and she was told to concentrate over and over again. And socially, she had a lot of good friends, but she was very clumsy, and they laughed. It was kind of, they all laughed too, but sometimes she said she felt like she was on the outside looking in. She just couldn't really grasp full relationship. Then she started riding a scooter, and this is like about her because she positioned herself so far forward that they said she looked like a potato on wheels. And she was really doing that. She kind of realized that she was doing that because that's where she found her center of gravity. She could not maintain, her peers were sitting on it. And so as she began watching her colleagues at Krabbit speak about the topics of the saddle seat that we're kind of going to go into, she learned more and more of her associated what she was learning in school as a PT to what she was doing until she saw it presented in the way to the patients that they were looking at. And so she always sitting for long periods of time. And while her natural position on the scooter was so different from anyone else, it was considered laziness, but it's just what she had to do. Know that that's why these things were happening to me. So it, again, increased awareness and support for that. So let's talk about some motor difficulties in daily life, right? So this is core muscles. It's exhausting to sit in more standard, sit pretty positions like a PT might say today. So that W-sit gives them a wider base of support. Spreading out, leaning over, getting as much control and support as they can in order to kind of gain a focus and just a grounding for more security. They want to blend in place, and so they're not meaning to be disruptive, but their body movement patterns of what they have to do is very disruptive. They have reduced mobility in their spine and their trunk, so they have eye issues as well. And then they have challenges in gym class, physical play, and endurance activities. So when it comes to the forearm skills, their forearm muscles have a lot of tension because of the posturing force over time. They have uncontrolled hand movement patterns, and when they're moving their feet, there's a discoordination between the hand and body coordination of that. So it actually reduces this, and it's perceived as disruptive or aggressive behavior, and they're often scolded for this. So this is Kenna. This is how Kenna works on her report that she's had. She's really spread out. She chooses to be on the floor more often when she's kind of trying to concentrate and keep her concentration while she's doing work. So how do we provide support for these more mobile, clumsy, low tonal trunk individuals who have ADHD, and autism? We can reduce activities that require handwriting. If it's really messy and really hard for them, are we really learning what they actually know, what their receptive understanding is? Can we make it easier for them by giving them a block to serve and digital tools for written work? Giving them regular breaks to give their body a little bit of large motor tasks to help prep them and prepare them and get them ready for more focused tasks. And then focusing on the ergonomic seating reports. We did computer access evaluations. And there was a period of time where we got a lot of children coming in with computer access assessments and tools to utilize. They would place them in a more functional chair, because activity supported chair, and they didn't have fine motor skills problems. They were able to type accordingly or write or do something, because it just is engaging. Our first thing to think about is, if they have this diagnosis, is maybe we go to too much technology sometimes, and we need to really make sure we're assessing the posture as well. Tense muscles that fatigue quickly. Think about most standard school chairs. There's really no support or stability. These kids are all over it. You guys are probably changing position in the chair a little bit more engaging, to kind of relaxing, to kind of stretch out. You're also moving around probably to stay awake because it's been a long week. So you're doing different things to keep your body awake, and they're doing this just to try to focus at the saddle seat. Why the saddle seat? Well, this is not a new concept. Therapists and parents with children who were in wheelchairs, when they were doing their riding therapy, they know sports when they were on the horse. While the movement of the horse did play into the role, what about the actual saddle position itself of helping that? So in 2008, Kravitz started looking at this a little bit more specifically in their community, and they developed the first saddle seat. Over the years, they've gained a lot of extensive knowledge about how this can kind of help and what the positioning is. And while the research is limited, there are some existing studies for that support. So in 1953, studied the relationship between the lordosis and the hip angle with using x-rays. But he conducted this x-ray with a lying position. And hopefully all the clinicians on our backs, when we hip our flicks past 60 degrees, the pelvis is tilted backwards and the spine flattens out. But while the human body hasn't changed, our technology has evolved a little bit to this topic. But he used MRI scans in the seated position. And they discovered that by maintaining a 90-degree hip angle for extended periods, it's impossible to fall back into a posterior tilt, leading to the collapsed posture. However, sitting with the hip at approximately 60 degrees allowed for longer sitting durations with significant less stress on the body posterior tilt. And sitting is physically demanding. Like, you're having to sit here for an hour. It's been a long week. It's more demanding today than it was at the periods of time. I'm not even designed to stand in one static place. I shift my weight all the time. So the challenge is even greater for those individuals who have disabilities. We talked a lot about that this week with various types of equipment. So flat seat versus saddle seat. The hips are at 90. The hips are at an open angle. You can see the C curve, and you can see the more natural S curve. And then I keep looking at my thing. This keeps going off. I'm going to have to look at it. And then we have the collapsed position and a more upright position. Knees flex under our body, feet underneath us. When you do that, you naturally pull into a more open posture, more dynamic supported system. A wide base provides larger surface area and good support. Proximal stability allows for distal mobility. So that because it has the base of support to distribute the weight evenly, that's how the pyramid's able to stay up. The Leaning Tower of Pisa. It tilts because it has an uneven foundation setting, but the foundation is wide, so it doesn't fall over. Think of basketball tournament one now. When you're guarding somebody, you're not standing with your feet together trying to get them. You're wide base of support, so you have more dynamic mobility and movement. It's the same principle applies to seating. And more engaging, we need to make sure that we have a well-established concept of postural stability component for all of those positions. And it's just kind of everything, kind of our stability, our relaxation, our comfort, our activity level revolves around how stable we are within the position of our pelvis. So they did a school project in Norway. They did different things. They had a classroom chair, and then they did everybody sat in the jockey. For the children who were more typically developing, didn't have any trouble, they were very successful in both chairs. They moved around in both, but they were a little bit more. So that's typical. But the two children that had ADHD had significantly increased attention span, improved better on their test scores during that. So the whole class overall, for the 8 weeks they were in the Kravitz chairs, the teacher had a more successful teaching experience as well for her day. So let's meet Born. He's 9 years old, 88 in the study, and had ADHD. So physiologically, we are looking at the symmetry, right? So we are more of a rounded posture at 5 kilograms, right? Think about the weight of your head. When you lean your head forward and it's just dangling, that is on your body. And you're also collapsed. So you're not breathing well. You're not moving. It's also your GI. It impacts a lot. When we sit more upright, we are more stable, symmetry and balance. But our concentration and there's a lot of concentration to kind of sit and take what the lesson was doing. So here, let's look at this, right? So he is, the first picture, his feet are off the floor. He is back in that chair, but he has a rounded, he's manipulating the book. The next seat, his feet are on the floor. He's back. He has a little bit of anterior tilt, but the position of the back support, his shoulders are still engaging his core. His pelvis is a little bit more aligned, but he's not engaging that core. When you tuck the feet, you can get a little bit more control and weight bearing, joint compression, sensory input through the lumbar back. He's up and he's engaged. His shoulders are down. His head is still forward because he's looking at a book. But his hands, the fine motor control of his hands, he's able to do a little bit more grasp and pinch of the paper, not of that. And the results of that were, the teacher said, the main difference is that he stays in his chair longer. He's less restless. He concentrates better. The classroom is calmer. And he does consider to be disruptive and maybe behavioral when actually he was just trying to focus and attend like the other children in the class. The father said the chair worked better than medication. That's a pretty short, poignant statement, right? Because the amount of medication is sometimes that we're with a little bit more postural support and understanding of why, and gave them more control, then maybe that wouldn't have to be as significant as what it is. And he himself said the backrest and footrest felt better. So when it's coming from an atypical seat all day, and he didn't slide off the seat. So he knew he was trying to sit and he was sliding, but that sliding was considered disruptive and maybe behavioral when he really was just trying to sit. Pull up my feet here. There's no sound. And actually it's probably good because everyone's talking in Norwegian anyway, so it gets very disruptive. So I just tried to use this like a mouse. Okay, so Marcus, remember he tips and falls in the kitchen chair all the time. But he did a trial with a jockey. He sat for 30 minutes. He completed one task at a time, the whole time, while he was over at different times. But he experienced less back pain and remained seated calmly with only small movements for his stimming. So he's the one that has to maintain his attention to himself and kind of give himself some of the modulation tasks that he utilizes. But he was able to successfully do that for 30 minutes. And then we have Thea. She dislikes sitting for the entire lesson or homework. She's always up, down, moving around. She was cartwheel, flip around, and just kind of speak out. The child with the jockey chair, he sat for nearly 2 hours. She didn't sit for nearly 2 hours straight, but for 2 hours she was engaging. Then around a little bit, she'd come back and she'd sit down in the chair and she would engage again. And she said it's easier to do table activities on the saddle chair. So she voiced that she liked that, and Christine knows both of these families very well, and she's got a lot more social interaction, a little bit more self-identity and awareness and confidence in herself. So she's communicating with her family and making a little bit more friends and things like that because she's feeling a little bit more secure of herself as well. So when we look at the jockey saddle seat, and the experiences with autism and ADHD, we talk about our complex individuals. We're kind of looking and treating them in a little bit of a different manner, maybe still utilizing this for control and function and support. But there are a lot of individuals out there who are struggling, and it's due to a neurological or neurodevelopmental disability and diagnosis, and maybe starting to provide an appropriate posture for them. And in certain situations, if one student has it, we found it's not necessarily that bad to provide it for everybody. Everyone's not moving, sit cushions that help and get a little bit more of movement, and getting ourselves into more dynamic postural positioning. Karen Kangas talks about this. Tom Hetzel for Bride talked about it forever. At one situation, I put my child on the corner of a table to help a family understand why we needed to do some additional seating for a really complex thing. He was doing the 18R. She felt like she was falling out of the chair. She was not stable. So I had my son sit on the table and took pictures. I said, lean to the left, lean. And when he would do it, we got to a position. I was like, and I sent it to the mom and he's like, oh my gosh, she was doing it. And she's like, you're right. You feel like she's falling. Now I understand why we need to go into this a little bit more complexity to get her more stable so we can center her nervous system and her vestibular impairment. So there's lots of things we can do for that. But the resting position on the hips and pelvis in the neutral position and standards, the back support helps to give a boundary and control and stability and a little bit of input. The feet placed under the body helps us from sliding out. It gives us input. They're looking for input and proprioception. It gives them that. Clear sensory feedback from the seat because we're getting everything kind of moving and stabilized. We're supports where we need them to kind of give additional input and control. And of course, the aesthetics, it looks like the saddle. Another component that I had a therapist point out recently for this is individuals who have more hip extension contractures angle, right? Open the back angle, which puts them in a more reclined position, which is fine for a wheelchair. You're moving around and function, but if someone's really trying to engage and be functional and they have a hip extension contraction, you can control the amount of hip contraction and where the hip is placed by the foot rest, moving up and down. So I'm seated upright. I can still tilt if I need to have gravity assist either way. So the point of the jockey was more to kind of put the emphasis on making sure we're looking at postural control for our individuals who are more in this category of, I hope you were able to kind of process that and think about it in different environments and patient populations, and the activities and maybe some of the patient populations that you or your staff might be working with in your centers.